Hi, my name is Marlena Fejzo, and I am a Hyperemesis Gravidarum survivor, a Hyperemesis Gravidarum researcher. I have appointments at USC and UCLA, and I'm also the science advisor for the Hyperemesis Education and Research Foundation. Thank you for having me. Today I will talk a little bit about my quest to understand Hyperemesis gravidarum and how I got here, and some of the research that I've done over the years. So I had hyperemesis back in 1997 and 1999. In 1997, I was never diagnosed, even though I missed 8 weeks of work and went into the hospital for IV fluids twice. In my second pregnancy, I was much worse. In 1999, my hyperemesis gravidarum was so severe that I could not move without vomiting. That means that for 10 weeks, I had to lie completely flat with a fan in my face, or I would just start vomiting nonstop. I could not eat. I could not drink. I could not get up to go to the bathroom. I couldn't sit up. I could not brush my teeth or take a shower. And so the doctor gave me IV fluids, and I had a Zofran pump in my thigh at first. But then I lost so much weight that there wasn't enough fat in my thigh to absorb the drug, and it was put in IV piggyback. Eventually, I was put on TPN. I had hypersalivation. I had so much saliva running down my face that I had burns from the acidic saliva on my skin around my mouth, and so my doctor prescribed me a suction machine like they have at the dentist's office to suck off the saliva. And I was so ill that eventually I lost the baby at 15 weeks gestation. Because I have a PhD from Harvard in medicine, I decided after this horrible experience that was virtually starvation in pregnancy and torture in pregnancy to look into what was known about the disease. And I found that there was very little known about Hyperemesis gravidarum, probably mostly because of the thalidomide disaster in the 1950s, where people were given thalidomide for severe nausea and vomiting, and the babies were born with limb deformities. There are also many lawsuits to drug companies when babies are born after drugs are taken for medication in pregnancy, which deters big pharmaceutical companies from investing in research into therapies for this disease. So therefore, I decided to devote myself to studying the disease, and in 1999, I started a survey that I put online, and at the time, a nurse who also had hyperemesis named Kimber McGibbon filled out my online survey, and she said in the comment box that she was going to make a web page or a website on hyperemesis so that we could learn more, and also so that there could be an online support group for women with this disease. And so she made her website, and I asked her if I could put my surveys on hyperemesis to do research up on her website, and she agreed, and that's when we started our partnership between what became then the Hyperemesis Education Research Foundation and UCLA and USC, where I work on hyperemesis. What is Hyperemesis gravidarum, or HG? Well, 70 to 90% of pregnant women have normal nausea and vomiting of pregnancy, and as many as 18% of women in the United States take medication to treat mild or moderate nausea and vomiting of pregnancy. And up to 2% of women has what's diagnosed as hyperemesis gravidarum, or persistent nausea and vomiting of pregnancy that's accompanied by at least a 5% weight loss, electrolyte imbalance, and IV fluid treatment. In my studies, the clinical criteria is IV fluid hydration for dehydration caused by nausea and vomiting of pregnancy. In 2012, there were over 375,000 emergency room visits and hospital discharges for hyperemesis gravidarum, with an estimated $324 million in inpatient costs and $290 million cost of medication to treat it. I have been working with the Hyperemesis Education and Research Foundation, which is really a pioneer in hyperemesis gravidarum education and research. The website is www.helpher.org, and there it is a great resource for education, for what's going on in research, and for support. So as I said, I have partnered with them, and they helped me with recruitment for my studies. So in 2015, the Hyperemesis Education website had over 250,000 unique visitors. I also have a YouTube video that's had 16,700 views that has been used to recruit for my studies. I've been contacted by over 4,500 women. Among those, 2,700 are eligible to participate in the study, and 1,000 of those are women with hyperemesis gravidarum. Each woman who has hyperemesis is asked to recruit an acquaintance who has had at least 2 pregnancies with no nausea and vomiting or normal nausea and vomiting, no weight loss or medical treatment for nausea in any pregnancy. The women with HG are asked to send their medical record confirming IV fluid treatment, and all participants in the study are asked to send in a saliva sample for DNA analysis and fill out a very long survey that has all the questions that I could think of and Kimber could think of related to hyperemesis gravidarum. So from this survey, we've had over 24 publications. The survey asks questions on patient and family history, pre-existing conditions, and pregnancy nausea. It asks about the pregnancy history, the symptoms, and the treatments. It asks about maternal outcomes, such as post-traumatic stress symptoms and recovery time. It also asks about fetal outcomes, such as preterm birth and colic, and child outcomes, including neurodevelopmental delay and allergies. One of the biggest questions that women have about hyperemesis is whether they're going to have it again. So one of the first studies that I did was a recurrence risk study. We had surveyed a number of women who had had hyperemesis, and we went back and asked them again if they'd had a second pregnancy yet, and if they had, did they have a recurrence? And 81% of the women reported that they did have a recurrence. 26% said that they were worse in their second pregnancy. 30% of the women said that they were the same, and 44% said that the second pregnancy with hyperemesis was not as bad as the first, with the primary reason being that they were more prepared the second time. They knew which medications worked and were treated more quickly. Over a third of women reported that they would not get pregnant again, primarily because of the experience of hyperemesis gravidarum. We also did studies to try to understand who those 19% of women are that do not get hyperemesis again. So we looked at partner change, and we found that a change in paternity has no effect on the risk of recurrence. We also looked at psychiatric factors, such as post-traumatic stress symptoms following an HG pregnancy, and women who had psychiatric symptoms after a hyperemesis pregnancy had no different risk than women who did not have symptoms. The fetal and child outcomes are also quite significant. As many as 15% of the women in our study reported terminating a pregnancy specifically due to hyperemesis gravidarum, with the primary reason being no hope for relief. The women who terminated were more likely to say that their doctors were uncaring or did not understand how severe their symptoms were. We've also found a 4-fold increased risk of poor fetal outcome, primarily preterm birth. and a 3.3-fold increased risk of neurodevelopmental delay in children exposed in utero to HG. It is not enough to say that the child is born with 10 fingers and 10 toes. The severe dehydration and malnutrition and stress in pregnancy results in long-term problems. There's also a 3.8-fold increased risk of physical effects in the children, including increased risk of allergies, reflux, and chronic infections. And we have found a 3.6-fold increased risk of long-term emotional and behavioral disorders. In 2015, we reported our groundbreaking findings of an increased risk of neurodevelopmental delay in children exposed in utero to HG compared to controls. The children were 8 years old on average. Mothers with HG reported that their children had been diagnosed with attention deficit disorder in 19% of the children exposed to HG compared to 5.6% of controls. Learning difficulties and delays were reported in 12% compared to 3%. Sensory integration disorders and sensory processing disorders were diagnosed in 20% compared to 9% in controls. Social developmental delay or social anxiety was reported in 10% compared to 2% in controls. Speech or language impairment and delays were reported in 24% compared to 11%. Overall, this amounted to 49% of the children in HG families having a neurodevelopmental diagnosis compared to 22% of the control group. Maternal outcomes are also significant. Approximately 26% of the women in our study lose more than 15% of their pre-pregnancy weight, and 22% have symptoms that last all the way until term. 18% of the women in our study report full criteria post-traumatic stress symptoms, and post-traumatic stress symptoms are more common in women with symptoms that last all the way until term. A third of the women in our study decide not to have any more children specifically due to their hyperemesis pregnancy. In addition, reports of Wernicke's encephalopathy are on the rise, and that is a completely preventable disease that is related to a thiamine or vitamin B1 deficiency secondary to HG. In addition, there have been 6 maternal deaths reported in the literature. We also see increased risk of reporting 7 common conditions, including anxiety and cavities, and reporting of 50 rare post-pregnancy conditions such as blood clots. We have done several studies on treatment effectiveness and safety. Our first publication was in 2008 on the trends in treatment. 765 women reported on 25 different treatments that they had for hyperemesis for 1,193 HG pregnancies. The most effective treatment self-reported by these women were serotonin inhibitors, or Zofran. One of the striking findings of this study was that vitamins were taken by less than 1 out of 3 women with hyperemesis. And this is very serious considering these women are not getting the nutrients that they need because of their nausea and vomiting. In our second study, Antihistamines and Other Prognostic Factors for Adverse Outcome that was published in 2013, we found a 4-fold increased risk of adverse fetal outcome, primarily preterm birth or birth prior to 37 weeks gestation. Early symptoms, gestational hypertension, and antihistamines were all significantly associated with having a preterm birth. And I know that others are going to talk about this later, so I'll just briefly say we also published a study last year on ondansetron and risk of adverse fetal outcome in the United States, and in our study, we found no evidence to support a teratogenic risk of ondansetron. I'm a geneticist in training, so one of the studies that is very near and dear to my heart is to try to understand the cause of Hyperemesis gravidarum using a genetic approach. The first thing that I did was to see if HG runs in families suggesting a genetic cause. The etiology of HG is unknown, and it has commonly been assumed that it is caused by HCG, estrogen, and or psychological factors, when there is really no good scientific data to support these theories. We have found a 17-fold increased risk of having HG if your sister has HG. This is the highest risk factor for having a hyperemesis pregnancy after having a HG pregnancy in a prior pregnancy. In addition, a third of women in our study report that their mother was affected by more severe nausea and vomiting of pregnancy or hyperemesis. A twin study was done in 1992 that showed that identical twins were twice as likely to both take antiemetics than fraternal twins, suggesting a genetic component. And more recently, Kaladrakonda published a twin study of hyperemesis and nausea and vomiting of pregnancy that showed heritability for the presence of nausea and vomiting of pregnancy is 73%, and over 50% of the variation in severity is heritable. Given the evidence that hyperemesis runs in families, I did a whole exome sequencing study on 5 families with Hyperemesis gravidarum. The family shown here has 5 sisters that all had severe Hyperemesis gravidarum, and 2 sisters had normal nausea and vomiting of pregnancy. The mother and the aunts all had normal nausea and vomiting of pregnancy. The 5 sisters who had hyperemesis all had a rare, unique mutation in their RYR2 gene. This mutation was not seen in the unaffected siblings, the mother, nor the aunts. So what is RYR2? It is a stress-induced calcium channel. It's expressed in the vomiting center of the brain. It's involved in thyroid function. It is linked to cyclic vomiting syndrome. The ryanodine receptor family has already been shown to be linked to emesis. A drug target for the receptor is propranolol or indirol, and it is all part of the 5-HT3 receptor-mediated vomiting pathway, which has been worked out in the animal model, the least shrew. Last year, we published our findings on the genetic analysis of Hyperemesis gravidarum that revealed the association with the intracellular calcium release channel RYR2. We published on the family I just showed you and another family with 3 siblings that had hyperemesis and also had a more common mutation in the RYR2 gene. That more common variant was also seen to be increased in the Norwegian hyperemesis and Australian hyperemesis cohorts. In addition, I did a copy number analysis of the RYR2 gene in over 100 individuals with hyperemesis that required total parenteral nutrition, so the very severe end of the spectrum, compared to 139 controls who had no nausea and vomiting. And in one of those patients, we identified a novel deletion in the RYR2 gene. So what is next? We have a lot of very exciting things happening next year for hyperemesis, and I just want to give you a little taste of what's coming. I have partnered with the personal genetics company 23andMe. This company collects saliva samples from their customers and reports on health and ancestry. They also participate in research. Our partnership will result in very exciting findings that will be reported very soon. So can we cure HG? Our genetics findings may be bringing us closer. In 1980, there was a patient presented with HG and thyrotoxicosis and was treated in the hospital with propranolol, which, as I said, is a drug target to the RYR2 pathway. 2 weeks later, at 18 weeks gestation, the patient was readmitted with vomiting, which was controlled by reintroducing propranolol, which she had discontinued. There was no recurrence of her vomiting so long as she had a maintenance dose of propranolol. While this is only one case, it does suggest the possibility that with the genetic findings, we will be able to tailor treatment towards individual causes, genetic causes of hyperemesis. Currently in beta testing is our HG Care app. This app was a code for the mission finalist last year in a competition at UCLA. The key features are medication and treatment tracking and alerts, symptoms and weight loss tracking and alerts, nutrition, fluid, and vitamin tracking and alerts. There's also a place to enter notes and journal entries. You can enter what foods you've taken and what fluids you've drank each day. There's also access to online resources and support specific to HG. And in the future, we will be able to use it to connect to nurses and doctors to share data directly in real time. The HG Care app allows daily input and tracking of food, fluid, vitamins, and medications, symptoms of nausea, vomiting, retching, and weight. And it also provides weekly summaries of symptoms versus medication usage and food intake and weight charts. We are hoping that the app will be free to download next year. Thank you again for having me. I just want to also thank the doctors Patrick Mullen, Kirsten Jensen, Khalil Tabbage, and Dennis Slayman, the statistician Frederick Schoenberg-Pack, our app developer who ran the team, Michelle Chan, and of course Kimber McGibbon, Anne Marie, and Jeremy King of the Hyperemesis Education and Research Foundation. Thank you very much.